തിരിച്ചു വയ്ക്കും. ഇത് ചാർജ് ഇല്ലേ? കുത്തിവെക്കും. Hi friends. Hi friends, we will start the program. At the outset, let me thank the DocTutorials for providing an opportunity to meet you all and present this topic to you. Hi friends. Hi friends, we will start the program. Meet you all and present this topic to you. Yeah, you can send me the questions and your queries on the topic in the chat box. I'll address to that. Okay. Yeah, in this short 45 minutes or 1 hour of session, what we are planning is to discuss what has been asked before in the previous FMGE exam. And these questions, as you know, anesthesia is a very small and very light topic. You will straight away get questions which you can answer very well. To avoid an interruption in between, I'll go ahead with the topics, and if you have any queries, please message me towards the end where we will discuss that. Okay, so that is a plan. Yeah, so the first one, we will see the questions, and in between the questions we will discuss some data regarding that which you can reproduce for the exam. Please see, this is very simple, and I will go through the topic as per the previous year's questions. Coming to the first question, which of the inhalational anesthetic agent use special vaporizer? That is a question. Now, it is very simple. As you know, if you can look into the MCQs, you can see that desflurane is there, sevoflurane is there, isoflurane is there, and halothane is there. Which is so special among this? Now, it is very simple. As you can understand, desflurane has got a very low boiling point. Now, it actually boils at room temperature. It is the one which produces a very high vapor pressure. So, a volatile agent which boils at room temperature and whose output can be varied depending upon the temperature, because it is produced very high vapor pressure, needs special kind of vaporizers. Especially the vaporizer which we use for desflurane are called as Dec'6 vaporizers. They are temperature regulated or electrically powered vaporizers, while other vaporizers used for sevoflurane, isoflurane, halothane are all specifically doesn't need any electricity to function. So that's advantage. That is very specifically asked. Now you know desflurane is probably one of the latest volatile agent which has come into the market, and that is why you get very frequent questions on desflurane. So I'll just show you what is vaporizer. If you are not familiar, this is actually what is called a vaporizer. It is nothing but a special instrument which is where you fill volatile agent and then you can use it for delivering it to the patient. Now one point what you need to take into mind is that vaporizers are agent specific. Agent specific in the sense you can fill only one, it is agent specific. We can fill only one vaporizer with only one volatile agent. For example, as you can see, the yellow one here, the first one on the yellow is used for only sevoflurane, while the other one, the second one is only for isoflurane, third one for halothane. So that means they are agent specific, and please remember that. Now what I was trying to tell you is about this vaporizer, which is desflurane vaporizer, which needs electricity. Electricity is needed. And more, it is called Dec'6 vaporizers. Dec'6 vaporizers. So friends, remember about desflurane vaporizer. Don't forget that. Now a few more questions which you can recollect about desflurane is that it is an agent which comes into the body and get eliminated from the body very fast, because their blood gas partition coefficient of desflurane is very less as 0.42. That means it doesn't mix in the blood. So hangover effect is not there, unlike the other extreme where you have halothane, which is full of hangover effect. That means you take halothane, you will be sleeping even the night and the next day also. That is why we don't use desflurane and we don't use halothane for daycare surgeries, while we can use desflurane for daycare surgeries. That means you can induce patient fast, and once it used, you can eliminate also very fast. There is no hangover effect for desflurane. So that is the latest among the volatile agents. Now coming to the next area where you get maximum number of questions is about CPR or cardiac arrest. Okay, yeah, very good. I can understand your answers. That's fine. Now we will see the second aspect. If you have any doubts on desflurane or vaporizer, please share it on the chat so that I'll answer it accordingly. Now coming to the second area, this is a 100% sure question as far as FMGE exam is concerned, because I've gone through few question papers at least for the past 3-4 years. I've seen some glimpse of a cardiac arrest or a CPCR related question on that. The most common area they ask is what are the method or what is the order by which you approach a patient on cardiac arrest, what are the drugs which we use, what is the ratio, etc. So we will just finish it off in a very short time, the important area, so you will not make a mistake. Coming to the question, at a random place you saw a guy collapse. You started CPR after checking vitals, and soon advanced cardiac support arrives at that place. What should be the next step of management? Now for that, yeah, very good. That's answer. You ask them to apply the paddles while you continue CPR. Very good. Now before advancing further, I'll just tell you what you have to do when a patient go for cardiac arrest. Number one, when you see first a patient who needs help, the first point what you need to remember is called scene safety. The scene should be saved. So scene safety is the first step which you should identify when a patient in cardiac arrest. You mean to say that you should be safe to save the patient. Now, second is response. Check for the response. Response can be checked within 10 seconds. It has to be checked within 10 seconds. Two responses have to be checked, whether the patient is breathing or whether the patient has got a pulse. The pulse is usually checked at the carotids and the breathing is checked by looking at the chest movement. This should be limited to 10 seconds. You should not go beyond 10 seconds. Within 10 seconds, you should make a diagnosis. So that is the second step, very important. Scene safety is the first, second is response. Now, third, once this is not there, once patient is not breathing, no pulse, then you should ask to help. That is call for help. Call for help and ask them to get an AED. That is a third step. These steps or the sequence by which you do on a cardiac arrest has been repeatedly asked. Okay. So, scene safety, response and call for help. Now, then comes vital, again to confirm and start compressions. This is how you should do. Now, they have told you that once you in a random place you see somebody who collapse, you check for the response and you see there is no response, then you call for the help, and then on the scene you started compressions. As soon as you start compressions, what you do, the second agent, or the advanced team, or somebody whom you already call for help arrives at the scene, and what you have to do then. The point here is that when somebody comes to help you, you are already compressing, you should keep on continuing the compression, and the other guy who has come or the advanced team who has come should apply the paddles of the AED while you should continue the compression. Now, why this question become important is the key idea of this question is that you should not interrupt. You should not interrupt the compressions not more than 10 seconds at any cost. 10 seconds is the maximum time you can interrupt a compression once you start the cardiac compression of an arrest patient, and between you switching off the rescuer or doing a defibrillation, etc. So, whenever the people who has come to help you is applying the paddles of AED, you should continue the CPR. Handing over the patient to them and leave is absolutely an out of question. Stopping of CPR is absolutely not there, because when the paddles are applied, you should continue compression, and only when the shock is being delivered, you stop the compression. Okay. Now, continue one round of CPR and then use defibrillator. No, the concept is as soon as the defibrillator is ready, early defibrillation is the rule. Early defibrillation is the rule. Okay. So, I hope the point is clear. Now, we will just discuss something about the drug of choice is adrenaline. As you all know, the drug of choice is adrenaline. It has to be given 1 milligram. And the newer concept is, whenever you come and apply the paddle, you can diagnose the rhythm into two. One is called shockable rhythm and non-shockable rhythm. Once it is shockable rhythm, what are the shockable rhythm? Ventricular fibrillation or ventricular tachycardia without a pulse. These are the two shockable rhythm. Ventricular tachycardia without pulse and ventricular fibrillation. Very common question. Non-shockable rhythm is asystole. Asystole means patient has got just an ECG is a straight line. That's all. Asystole. Okay. And second is pulseless electrical activity. The second one. So pulseless electrical activity and asystole are the non-shockable rhythm where you don't have to shock, while shockable rhythm is ventricular fibrillation and VT without a pulse. So the concept is when you have a non-shockable rhythm, give adrenaline as early as possible. This is the concept which has come up in 2020. Okay. Now the second drug also you give is adrenaline, and the third drug once you think that adrenaline has to be supplemented by something, you can think of amiodarone and lignocaine. I am just cutting short for want of time. The dose of amiodarone is 300 milligram as a first dose IV and followed by 150 milligram. Lignocaine is 3 milligram and 1.5 milligram. So these are the doses and the drug. But the drug of choice in cardiac arrest is always adrenaline. Remember that. Okay. Now, one more point which you need to remember about drug is about atropine. Very common question. We always have an idea to give atropine when the patient is in cardiac arrest from an earlier times. But now they say that atropine can be given only when there is a documented bradycardia, symptomatic bradycardia, then only give atropine, not for every cardiac arrest. And that too, the dose they have updated in 2020 as 1 milligram. Okay, these are the important questions which you need to understand about the drugs which we use in cardiac arrest. Now, another ECGs to diagnose. I hope we will classify them into A, B and C. Can you make a diagnosis of A? Can somebody make a diagnosis of A? Yeah, it is very easy. Now, you always remember whenever you get an ECG, you always go by the standard method of reading. See for the PQRST and the PR interval and things like that. But if you are in short of time, the simplest way is to identify a P wave and a QRS complex. As you can see, yeah, very good, Doctor. It is actually atrial fibrillation. It's very easy because you look at the two things which I always look first is P and QRS. That's the easiest way. If you have P, that means atrium is contracting, and if you have QRS, that means ventricle is contracting. Clear? So look here. There is no documented P here. You cannot see a P. It is atrial fibrillation. It is atrial fibrillation. I'll say yeah, very good. C is ventricular fibrillation. Very good. That's correct. Now I'll give you the key. See, when you think that it is something like this, it is fibrillation. While P wave is like this, you can definitely see a P wave like this. But here you cannot make a correct P wave. Instead, it is fibrillating. The ventricle is fibrillating like this. It is not contracting. That's why you are not getting a P wave. Now, when you get atrial fibrillation, you have to look into two things, whether it is stable or unstable. If it is stable, no, nothing to worry. If it is unstable, you should think of methods by which you can reduce the rate, because the problem with atrial fibrillation is that atrial fibrillation, if the rate get conducted into ventricle, it can go for a higher ventricular rate, which can be detrimental. So you control the heart rate by using a beta blocker or a calcium channel blocker. Okay, so that is about atrial fibrillation. The first one, very easy to identify. Look for the P wave. You see there is no P wave. It is just baseline, fibrillating. Instead, you will get also another type which can confuse you, like here, something like this in the P wave, and then you have the QRS, a P wave. Then you call it as atrial flutter. Here, at least there is a flutter or a sore tooth pattern. So that is how you make a difference. Don't worry about that. They don't ask much of an atrial flutter. Mostly the question is about fibrillations. Now, this is the second one. B. What is the answer B which you have given? B. Very good. Ventricular tachycardia. That's right. It is a ventricular tachycardia. Now, why we say that? Because the QRS complexes are formed. You can see a QRS complex which is broad. Broad QRS complex indicates that it is a ventricular tachycardia. Now, when the QRS complex becomes narrow, it is usually a supraventricular tachycardia. And when the narrow QRS complex with a higher rate becomes supraventricular tachycardia, while a broad QRS with a higher rate, it becomes ventricular tachycardia. Now, the question is, what is the first thing what you have to do when you have such a B kind of ECG? The first thing is to check for pulse. check pulse is the first one you do. If there is a pulse, don't worry, that means you are okay. If there is no pulse, you need to defibrillate. The other patient needs to be monitored, and you should think of the causes and try to control the rate. Now see this ventricular fibrillation. Ventricular fibrillation, the treatment is defibrillation. No question about this. How do you make a diagnosis? You cannot make a P wave, you cannot make a QRS complex, etc. Yeah, very good. So if you want to discuss further on that, when you see a ventricular tachycardia, check the pulse. If the pulse is not there, that means it is same as when shock has to be delivered. And if the pulse is there, you should actually see whether it is stable or unstable. Stable means there is no signs of ischemia. That means higher mentation is okay. There is no cold clammy extremities. The patient has got no chest pain. So if it all is there, that means it is going to be an unstable. In that case, you have to do a electrical therapy. If not, you can actually wait and watch. That is how we go about that, in stable and unstable. Now coming to the third aspect, which of the following system is depicted in the picture? This was last year question. Do anyone have an answer for this? It's a very simple question, has been asked multiple times. Very good. That's Mallampati. I think most of you know that whenever you see a picture with 4 open mouth or an open mouth with tongue protruding in anesthesia, it is Mallampati grading. It's a very common question. Now this is used to assess the airway or how easily you can intubate a patient when the patient sit in front of you in the pre-anesthetic checkup room. You can do it in two times. You can do how easily you can intubate when the patient come to your OPD and open your mouth. This is called Mallampati scoring, which is usually done in a very OPD basis and discovered by a person called Sheshagiri Rao Mallampati, a person from old Andhra, and he has done n number of investigation and observation, and finally came out with this method of assessing the airway. And this is world famous, and every airway assessment in anesthesia starts and ends with Mallampati. They compare it with a new method of assessing the airway. They compare it with a gold standard Mallampati. So don't make a mistake. It is such an important one. We're proud to be an Indian who described this. Now the commonest mistakes with the Mallampati is the other grading which comes across, which is AHA grading, American Heart Association grading. This is basically to assess the physical status of the patient. Okay. Okay. This AHA grading is essentially used to find out the physical status of the patient. Now, physical status in the sense means you accept a case for anesthesia while assessing its biological, biochemical, physical conditions. So if after taking all this into consideration, you give them a grading as ASA grading starting from 1 to 6. So ASA 1 is considered as a safe patient. He has less risk, or his physical status is better, while ASA 6 is a brain dead patient. So this is the grading of ASA, which is usually done for assessing the physical status, while Mallampati is used to assess the airway. That's a difference. Cormack and Lehane scaling is next one. I'll show you. This is a Mallampati assessment which we have seen. You can see this area is the place through which your endotracheal tube passes in. So 1 is considered to be easy because you have more space, but as you progress to class 4, you can see there is no space for the tube to enter into the pharynx. Now see, how do you assess? The easiest way is to look into the uvula. If you can see a complete uvula, then it is class 1, and if you don't see anything on the soft palate, it is class 4. See, if you don't see the tip of the uvula, or the tip of the uvula is missing, that is class 2, and the base, only the base is seen, that is class 3. That's the easiest way to assess. Nobody will ask you the details, but if at all they go to the next level, please remember that. This is Mallampati. Now this is Cormack and Lehane, the second method of assessment of an airway after doing a laryngoscopy. I told you, you can assess it in two ways. When the patient comes to your OPD, where you do Mallampati and assess the airway, while there is another method is after inducing the patient or making him unconscious or her unconscious, do a laryngoscopy, elevate the epiglottis, and then see whether you can see the glottis. That depending upon the vision on that area, you can classify them into grade 1, grade 2, grade 3 and grade 4. This is known as Cormack and Lehane scale. So Cormack and Lehane scale is intraoperative assessment, while Mallampati is a pre-operative assessment. That is how you can call it. Here, once you do a scopy and you see the complete vocal cord, both anterior and posterior, you can call it as grade 1, and only you see only the tip of it, only you can see the lowermost portion, then you call it as grade 2, and 3 you hardly see that, and 4 you cannot even see the epiglottis properly. So as you move from 1 to 4, your difficulty increases in Cormack and Lehane. So Cormack and Lehane scale is also for assessing the airway, and also remember this is done intraoperatively. So don't make a mistake. The other one was Mallampati was pre-operative. Next, identify the instrument given in the image. It's very easy. I hope you can recollect. Can anybody give me an answer for this? Is it a face mask, or is it a nebulizer, or a HFNO, or a Venturi mask? Please give your answer. This is a very, very common question. Yeah, we have got, I'm happy our Dr. Rajiv Dhawan sir is also in the group. Hi sir, hope you are doing good. Okay, that's right, Priya. What you said is right. It is actually, yeah, Ruk sir, that's right. It is actually a Venturi mask. Now the issue with nebulizer, I'll tell you the difference. Nebulizer also work with the principle of Venturi, but it is not a Venturi mask. That's the issue. Anesthesia face mask is a bit different. I'll show you those things. Now please see this. We will see one by one. Now you can simply say, or I can draw it here for you. Now if you see, this is the nose of the patient. You can see a small mask kept over this. Most of us have used that. Something like this with a small hole here on both sides with a metal string here, and this will be attached to the patient's head. This is called the simple face mask, or simple face mask, or it is called a Hudson mask. Hudson's mask. This is different. Here, this is an example of variable performance mask. That's another question. Variable performance means the amount of FiO2, the patient gets depending upon the patient effort. It cannot be controlled by the machine or by the administering healthcare professional. So this is an example. The simple face mask is an example of variable performance mask. Here, this is bit different, because if you look carefully, if only this much was there, only this much was shown, then it would have been a simple face mask. But as for example only this much was there, then it would have been a simple face mask. But as you see, there is an added portion here. There is an added portion which you can see here, which makes them into a Venturi mask. High flow nasal cannula is different, which I will show you. High flow nasal cannula appears something like this. It has got a small opening like this, which you can put it into one nose, and another cannula which can go to the other nose, and you give a very high flow oxygen to a tune of 40 to 70 liters per minute. That is HFNO, high flow nasal cannula, or HFNC. I'll show you the figure. Nebulizer is different altogether, which most of you would have practiced or seen in your OPDs. It also uses the principle, whether it is a Venturi mask or a nebulizer, both use the principle of Venturi effect. So that is how it is different. So in answer to this question is Venturi mask. Now please see this. This is an example of an oxygen delivery device where you can give oxygen. This is a simple face mask, and into which if you connect a Venturi device, this is the multiple Venturi devices which you can have, starting from the basal one to the highest one. Now what you need to remember is Venturi mask work on the principle of Venturi effect, number one. Second one, what you need to remember is this is an example of a fixed oxygen delivery device. Number 3, the maximum amount of FiO2 you can deliver is 0.6 or 60%. These are the 3 MCQs which is very commonly asked. Okay, so remember that. Yeah, color coding. Don't worry about the color coding. Nobody has asked color coding of oxygen delivery devices. But if you are very particular, remember that it starts from 24. It starts from 24 to 60. The maximum is 60. Okay, and this is the and why the color coding doesn't keeps very particular on Venturi mask, because it varies with companies, not even with the nation. Because unlike cylinders, there can be variations with the US and UK base, but here even in India itself the companies manufacture different kind of colors for different FiO2s. That is why we don't get questions on that. The commonest question that they ask is how much is the maximum percentage which you can deliver with a Venturi device, which is 60%. I hope it is clear, Anupam. Now this is another example of oxygen delivery device, a previously asked question, oxygen delivery device. Now the additional thing which you can see is a reservoir bag. This is the reservoir bag. Now why I brought this is to tell you a mask, a face mask, this is the face mask plus reservoir. Face mask is a variable performance device, but if you add a reservoir bag, it becomes a fixed performance device. You can deliver. That's right, it has been asked. Yeah, bag and mask. So face mask with reservoir actually becomes a fixed oxygen delivery device. Now there are 2 more questions which you can get. How much you can get at the maximum? This is a device which can provide you 100% FiO2. Now to add more into this question, please concentrate. Face mask plus reservoir bag can be of 2 types depending upon presence of a unidirectional valve. If the patient has got only one unidirectional valve, it can give to a tune of around 75% FiO2. If the patient has got, the combination has got 2 unidirectional valves, it can provide the classical 100%. So remember that face mask with reservoir is a device which can provide 100% FiO2 if it has got 2 unidirectional valve. Okay. Here there is no rebreathing. That is why it can provide you 100%. Here there is a partial rebreathing. That is why the FiO2 has fallen down into 75%. I hope the point is clear. So Remember that face mask with reservoir can give 100%. If there is only one unidirectional valve, it can give only 75%. Two unidirectional valve, it can give 100%. Now, this was a question which you were asking. This area is the HFNC, high flow nasal cannula, and the whole system become HFNO device. Now, this is the one which has actually helped a lot of people during COVID time. You know, earlier it was like you provide them oxygen, after some time the patient become hypoxic, and if the patient further deteriorate, there is you can keep NIV for some time, and even if the with NIV patient cannot sustain, the next option is to intubate him and then support with ventilator. Now, as you all seen during the COVID time, those patients who have gone to ventilator have hardly returned. There comes the importance of HFNO, or using HFNC. You can provide almost 96 to 98%. Some books even gives 100% FiO2, being a fixed oxygen delivery device. This also can provide almost 100% FiO2, saved lot of people from reaching onto ventilator. So this is actually something which bridges between a non-invasive ventilation and an invasive ventilation, and has helped to save a lot of people. So that is why this has been repeatedly asked as a spotter for your exam. So remember about HFNC and HFNO. This also delivers a very high very high flows of oxygen, around 70 liters per minute. That is one question. And the advantage is that it provides humidified oxygen, okay, and it also help to provide some amount of PEEP. Very rarely an oxygen delivery device other than ventilator provide a very good PEEP. HFNO can provide that. These are the advantages. So remember, these questions can all be asked for you, okay. Now, the next question. A sick patient in the ward needs supplement of oxygen. It will be given from which among the following cylinder? Very simple question, repeat question, multiple times they have asked. Okay, can anybody take a answer to this? So it is easy for me. Then I will go further. No, in a way, they are just asking you which cylinder or what is the color coding of an oxygen cylinder. Very good. All of you have got it right. It's a very simple question. Very good. So I know all of you know that these three cylinders, which are the very common question for our exam. If I ask you A, B, and C, can somebody give me an answer? Very good, Nadia. It is actually black body with white shoulder. Very good. Can somebody tell me what is this cylinder now? A, the capital A. The point what you need to remember is this cylinder has got a body which is blue in color and has got a shoulder which is half quadrant blue, half quadrant white. Blue and white. Can somebody? Yeah, very good. Blue is nitrous oxide. That is true. You have got an answer. Entanox. Very good. That's right. So now I hope all of you can remember. See, this is Entanox. Entanox is an equimolecular mixture of nitrous oxide plus oxygen. Very good. So that is why it has got both the features of oxygen of white and nitrous oxide as blue. So blue body with quadrants of blue and white become Entanox cylinder as in A. And then coming to B, this is B, your classic oxygen cylinder which has got a black body and white shoulder. Black body, white shoulder becomes oxygen. And then comes a C which is blue. Blue body and shoulder. Both the colors are blue, the shoulder as well as the body, which is nitrous oxide cylinder. Correct. Very good. That's right. I know most of you got it right. So we'll go to the next question. This is also a repeat question. A COPD patient admitted to ICU was on oxygen therapy and mask with 2 liters of oxygen. He was found to be hypoventilating. Okay. His PCO2 on the blood gas analysis was 64. Which of the following should be done? I'm waiting for your answers. The key points which you have to look here is, one, it is a COPD patient. Now what is okay, yeah, that's right. Nitrous oxide is that's true, 50 equimolecular mixture, 50-50, that's true, of N-nox. Now yeah, unfortunately B is not the answer. Increase FiO2 is also not the answer. That's why this may be a bit tricky question for you. No, I'll give you. I'm sorry that till now I didn't get a correct answer. No, it is not increased FiO2. I'll tell you why. See, please concentrate here. I'll give you the clue. When you have a COPD patient into your clinic, there are two things which comes to your mind. One, this patient has got a high PCO2, and they also have a low PO2. That means they have got a bit of hypercarbia and a bit of hypoxia. Okay, that is the idea. Bit of hypercarbia and bit of hypoxia. They don't have enough oxygen in their body, but they have a lot of carbon dioxide in the body. That is how a COPD patients usually live. Now, as you all know, hypercarbia is the most important stimulant to initiate a breath, isn't it? Carbon dioxide presence is the most important stimulus to initiate a breath. But remember, in PCO2, in COPD patient, it is basically the PO2. It is the hypoxia which actually drives them. It is the mild hypoxia which actually trigger their respiration. So I hope the background is clear. So a COPD patient is surviving with a bit of higher end of PCO2 and lower PO2 so that he can breathe. The hypoxia is the driving factor here. Now, with that idea you approach, his PCO2 in the blood gas analysis 64. Okay, it is hypercarbia only. That's fine. Now, what happens when there is an infection or something? It aggravates. The problem aggravates, and he start having accumulation of PCO2 further. Okay. Now, the breathing become difficult. The labored breathing starts in, and he actually finally cannot breathe. Because of that, he go for respiratory failure. This is how it happens. So you have two methods. One, you actually give them some oxygen. That is naturally what we think, because anyway carbon dioxide is accumulating, you can't do further. I will give some oxygen to this patient, thinking that if you increase the oxygen, what will happen? The PO2 goes, whatever oxygen is there will be washed out, and the PO2 actually, the drive of the patient to breathe goes away. So what happens? Increasing FiO2 makes the patient stop breathing. So that is not at all an idea in COPD patients. Similarly, decreasing FiO2, thinking that okay, I will decrease the FiO2, that also is not good, because a patient is happily living at 21 to 31 FiO2 administered. That is a usual administered FiO2 for a COPD patient. If you reduce it further, that is not possible. No, you cannot further reduce it. So that is also not there, because he is already on 2 liters of oxygen. You cannot reduce any oxygen further. 1 liter of oxygen is practically nil. So the minimum which you keep is 2 liters. So there is no question of reducing it further. Now, The third option, intubating. Intubating the patient, a COPD patient, is okay. But the problem is, it is very difficult to wean this patient off the ventilator after intubation. It's very difficult to make the patient off the ventilator once the patient is into an intubated and ventilator. So that is why now the current treatment for every patient on COPD, as you all know, is to provide a BiPAP, bi-level pressure. Bi-level pressure means we support the patient. We give some pressure support when the patient is inspiring as well as expiring. Initially it was only this much and this much. You provide them support so that the patient has got a pressure during the inspiration as well as during expiration. So pressure in both levels is called BiPAP. If both IPAP, inspiratory pressure and expiratory pressure, are in the same level, it is called PEEP. And in BiPAP, what happens is you support at two levels. When the patient is inspiring, you provide extra pressures so that the patient effort to breathe is reduced, patient have some rest, and when it is expiring, you provide some PEEP to prevent the collapse. So what happens is, in this process you provide them oxygen also to treat the hypoxia and eliminate the carbon dioxide also to correct the acidosis. So that is the treatment for COPD in the current scenario, that is BiPAP. Okay, so remember that bi-level positive airway pressure supplementation is the treatment. As you would have noticed in your clinical postings, most of the time you would have seen COPD patient onto BiPAP machine, which is a carryable machine, something like this, and a small tube will be there which will be attached, and there is a NIV mask, non-invasive ventilation mask, which will be connected to the patient face, and this provide the pressure, and patient will be happily settling down. And once the patient's acidosis and the systemic conditions have settled, you can gradually wean them off from the BiPAP, and patient will be comfortable. You don't have to induce this patient, and so that is why this has become the gold standard of treatment nowadays. Okay, I hope the point is clear for you. So remember this is a tricky question. Now another question. A young patient underwent surgery under general anesthesia with oxygen, nitrous oxide and desflurane. Okay, as you know, to provide anesthesia you always need a combination which is called the maintenance. During the maintenance you always need oxygen for maintaining the basal body requirement. So you need oxygen at a minimum of 33%. Then you provide nitrous oxide, which is usually given at a percentage of 66%, and along with that you give some volatile agent. This volatile agent is usually any volatile agent starting from halothane to desflurane. Desflurane is the best right now. So this was going on normally, and after that you extubated the patient. Surgery is over and you extubated the patient, means you have taken out the tube. Now after extubation you see that the patient is desaturating. Desaturating matlab the patient oxygen saturation came down. You always expect after extubation patient should always have a same oxygen saturation of 100%, no. But unfortunately you notice that it has fallen drastically to 90%, just for an arbitrary value. And naturally when you see a fall in saturation, what you will do? You will auscultate, and once you auscultate you found out crepitations. And what is the most common cause? That's the question. Yeah, very good. Yeah, I can see many of my favorite students are also joining. Yeah, that's perfectly right. It is negative pressure pulmonary edema. Actually this entity has been described in 1977, such an old time, for the first time, and it was in anesthesia that negative pressure pulmonary edema came in. Now we will gradually rule out one by one and come to that. See, pleural effusion is out of question. Why? Because you see crepitations here. In pleural effusion what you see? You don't see anything, because you practically, what happens in pleural effusion, you have a lung, you have a pleura, and then the whole space is filled with fluid. So essentially you don't see the small crackles or the crepitation conducted here. So that is out of question. And pleural effusion doesn't happen all on a sudden after the extubation. If it was there, it would have been before. Okay. Second is ARDS. To make a diagnosis of ARDS, you need quite a number of things. You need to find out an X-ray. Okay, X-ray should have an infiltrate. You should also have some time lapsed after an event. An infection should have been there. So at least it takes some time for the ARDS to develop. So time factor is also not supportive. Third, you need an ABG to find out the ratio, F by TV ratio. F by T frequency by tidal volume ratio should be there. That is also not there. And you should also rule out other causes of cardiac failure. That means it should be a non-cardiac origin. So all this has to be ruled out to make a diagnosis of acute respiratory distress syndrome, ARDS. Now coming to atelectasis. Atelectasis or collapse can be a possibility which can happen, but the chance for crepitations to present is very unlikely. Okay, and it usually happens bilaterally and not soon after the extubation. So the possibility of a negative pressure pulmonary edema comes here. Now what is actually a negative pressure pulmonary edema? Now as you can see, imagine this is your airway and this is your lung. It should breathe, inspire normally. Now suddenly after extubation or after anesthesia, some airway obstruction happened in the upper part of your trachea or upper part of your airway. Airway obstruction happens here. It may be due to the hangover effect of a volatile agent or a muscle relaxant acting with a longer duration of action. Something caused the airway to collapse. So the air entry from outside is stopped while your lung has been expanded by the muscle, by the thoracic cavity, which brings a lot of negative pressure inside the thoracic cavity, which actually cause the water to percolate or collect within the alveoli. This is called negative pressure pulmonary edema. The commonest reason for negative pressure pulmonary edema under anesthesia is soon after extubation. So that is why this is a very important question, and please remember this. This has been repeated. Okay. So that's answer. Very good. I'm happy that most of you have got through that. Now, which of the following anesthetic agent is best for cardiac? Very easy question. Is there any takers for that? It's very easy. We will go very fast on that. So, whenever you see a cardiac patient for anesthesia and volatile agent, it is always isoflurane. Why? Because isoflurane actually has got a coronary vasodilating property. That's the biggest advantage of that. Number two, it retains the baroreceptor. Baroreceptor reflex. Third, it actually reduces the systemic vascular resistance a bit. So not an issue. And then it doesn't cause an inhibition in, it doesn't inhibit the cardiac contractility. So because of all these reasons, isoflurane is a choice in a patient with cardiac disease, especially ischemic heart disease patient. Okay. Now, sevoflurane is not good for cardiac because when you see sevoflurane, think about children. Sevoflurane is an induction agent of choice for children. Okay. So answer is isoflurane. Nitrous oxide is not an induction agent per se, because its MAC value is 104, which is very high. You cannot, it is a very poor induction agent. Clear? So, any other answers? No. Halothane. Halothane is a very good induction agent, that is true, but you cannot use it in a cardiac patient because it reduces the blood pressure significantly. A rapid fall in blood pressure is there in halothane. So halothane, first of all, it's outdated. Nobody uses halothane nowadays. So it is outdated. Yeah, that's right. Altaf, as you rightly mentioned, it is in children. We have already discussed. So I usually use a mnemonic: sweet sevoflurane for the sweet children. A common question, which is an induction agent of choice for a patient for children. Okay, so that is why we use that. Now, which of the following structure is not encountered during epidural anesthesia? That's a very simple question. Any takers for this? Epidural anesthesia. A bit of anatomy question, but has been repeated. That's why I thought I'll share it with you. You can get a repeat on this. That's right. Very good. Dura. Oh, very good. All of you got it right. So the word itself tell you that. What do you mean epidural? What do you mean by that? Epi means outside. So you are actually depositing the drug outside the dura. So there is no point of puncturing dura. So dura is not encountered. Very good. That's right. All of you have got it right. Good. Just to give you an idea, if you are, I'll just brush through this. This is a spine, as you all know. Anatomy of spine. And you can see there is a lamina. This is a lamina. This is a, between the spine you have an interspinous space, isn't it? Interspinous space. This is the lamina of the spine. Now please see this ligament. The outermost ligament is a supraspinous ligament. And just inside, once you go inside, then you, between the spine you have another ligament. This is called interspinous ligament. Interspinous ligament. And then deep within, after passing through the interspinous ligament, then you have something known as a yellow ligament, otherwise known as ligamentum flavum. After that, your needle reached to the dura and you stop it there. You don't puncture the dura. This is the dura. So these are the structures which is pierced when you do an epidural anesthesia. First one is the supraspinous ligament, then is the interspinous ligament, third is the ligamentum flavum, and then you reach at the dura. You don't pierce that and you deposit the drug outside the dura. That is why it is called epidural. Okay, once you are doing spinal, you pierce the dura also and also the arachnoid space. Okay, that is the basic difference. Yeah, that's right. Ligamentum flavum is called yellow ligament. Okay, so we pierce the ligamentum flavum and just stop outside the dura. Now, this is also an important question. Can anybody give me the name? This was a spotter. I'll keep it here. Can anybody give me the name of this needle? Yeah, Dr. Najib, that's right. It is Tuhi needle. It is called Tuhi needle. It's called Tuhi needle. What is it used for? it is called 2He needle. How do you identify this? Number one, it has got a curved end. It has got a curved end. The tip. Spinal needles have got a straight end, while epidural needles, which is the classic example of 2He needle, has got a curved end, as you can see here. Second, that is the first point. Second point is it has got gradations. One is dark, one is light. So that is the second point. And third, it is a thicker needle. So this is used to do epidural anesthesia. Very common question. Remember that. Epidural anesthesia is done using a 2He needle, identified by three features. It is called epidural. Epidural. That's right. That is right. It is like a tiger mosquito in PSM. That's right, Dr. Najib. That's a nice way of remembering it. Now, this is what we have done before. We have seen this, how a 2He needle goes inside between supraspinous, interspinous, then ligamentum flavum, and then outside the dura. Now, coming to that, before laparoscopic surgery, what advice should be given to the patient by the surgeon? This was a last year question. Any takers for this? Any takers for this answer? First of all, our surgeon need not advise NPO because as soon as the patient come to hospital, they are not given food. So many of the time. Yeah, most of you are gone with A, but unfortunately, I'll tell you there is an issue. Yeah, there is a difference of answers. So I think I'll give you the correct one. See, before a laparoscopic surgery, whatever surgery, when the patient, if you are planning for a major surgery, when you're planning for a major surgery, you give an NPO advice. That is true. And it is like this: 2, 4, and 6. 2 hours for clear liquids. Four hours for semi-solids. And 6 hours for solid diet, isn't it? So there is if you look carefully, some books even say that 6 to 8 hours also. 6 to 8 hours also. That is because when the fat content of the food is high. Fat content, like if you take a chicken biryani or a mutton biryani, probably you will have to wait for 8 hours before surgery. Usually, to remember it as 2, 4, 6 will be a better option. Clear liquids like water, you can clear liquids, water or carbonated drink, etc. without solid particles. It is 2 hour prior. Suppose you have a surgery at 10 a.m. in the morning, you should stop taking clear fluids, everything, including clear fluids, till 8 a.m. By 8 a.m. you should stop everything. After this, nothing. Till here you can take clear liquids. Now, 4 hours is semi-solids and 6 to 8 hours is solid. Now, why I told this is because, what is it? How come not by razor but by clippers on the table? Yeah, kids D is also fine. See, if you look carefully, there is nothing 24 hours. That is too high because a patient will have problems of hypoglycemia. 8 to 12 hours is again a very high. 12 hours is out of question. You should not make them fast 12 hours. Now, on the table, hair removal by razor is the answer which has been recollected. Now, why? Because earlier we were thinking, if you would have practiced in the hospitals, you would have noticed that the previous day, a ward boy will come or the ward sister will arrange somebody to clean that area or the wipe using razor or some blade. They will shave that area where they are planning to do the surgery. But now they have stop that doing that, because they want to do, if at all they want to do it, they do it on the table. Why? Because they found out that when you do it in the previous day, there can be small aberrations where bacteria can lodge and can result in infection later. While it on the table, it hardly take 1 or 2 minutes there, and the patient is already on the cover of antibiotic. So that is why you don't remove or do, the preparation is not done on the previous day nowadays in many of the hospitals. So that is the correct answer here. On the table hair removal by razor. You can use razor or whatever, not an issue. Okay, what is your question? Yeah, now clippers, that is right. What about the child? Yeah, child also, there is only one question, which child also it's the same. Only thing, when the child is taking breast milk. So the simplest way to remember this is breast milk is considered as a semi-solid diet. So some books gives it as 3 to 4 hours in breast milk. But however, for easy remembrance, you remember it as 4 hours. So 2, 4, 6 if you learn, you can solve everything. And the breast milk is considered as a semi-solid diet. So that's the easy way. Okay. So no confusion about that. Now Ayurvedic product depend upon what kind of Ayurvedic product they take. If it is a solid diet or a Chavanaprasha kind of thing, you should stop it 6 hours prior. Okay. There is no mention on that in any of the books, so I think you won't get a question. Formula milk is again considered as a solid diet. Solid diet. So 6 hours of fasting is needed. Any other question? Okay. Now we'll go to the next question. What are these agents cause hallucination post surgery? I think we will discuss that later regarding the hair remover cream to be used or clip instead of clippers. I think we should, that may be an option. Maybe the expense cost while using that, or allergic response may be the reason. Yeah, I have few questions from you. You want to hear about the drugs? Yeah, drugs. Which drugs you need? Antihypertensive. Okay. Yeah, answer is ketamine. That's right. Very good. Very good. Yeah, I'll come to that. Majority have got it right. Very good. Perfect. The answer is ketamine. Now, a few of them asked about the other drugs which has to be stopped. I'll just answer that and come to this one. The most commonly asked question here, what you have asked is about antihypertensive, isn't it? Antihypertensive, it's very easy. There is only two things to study. One, all antihypertensive has to be continued except ACE inhibitors and ARBs. Except ACE inhibitors and ARBs, everything has to be continued when the patient is planned for a surgery. ACE inhibitors and ARBs has to be stopped on the morning of the surgery, because if you take it in the morning of the surgery and give spinal for this patient, the hypotension produced will be very high. Hypotension will be very high and difficult to manage. That is why standard practice to stop ACEI and ARBs on the morning of surgery, we skip that morning dose. Okay, so that's answer. And regarding insulin, we usually skip the morning dose of insulin because the patient is already NPO, so we don't give the morning dose of insulin. Okay, very good. We'll go to the next question. So hallucinations post surgery, all of you have got it right. I didn't even get a single wrong answer, so I'm very happy. So everybody knows that if you give ketamine, the ketamine act at the subthalamic level on NMDA receptors and produce what is known as dissociative anesthesia. Dissociate anesthesia. I hope everybody remember that. It's so nice to hear this word so that everybody remember. Now, once a patient come out of dissociative anesthesia, that means emerge from that, they used to have some kind of vivid dreams or fearful dreams or hallucinations to which they react in a different manner or a violent manner, and that is why it is called emergence delirium. the patient get into what is known as emergence delirium. They are non-pleasant hallucinations, emergence delirium. Okay, it is called emergence delirium. How do we prevent this? We prevent this by pre-medicating this patient with benzodiazepines. The commonest benzodiazepines we use nowadays is midazolam. So if you give midazolam before giving ketamine, you can prevent a great amount of emergence delirium that can happen after the surgery. Clear? Now, ketamine only cardioprotective among IV? No, dear. Ketamine should not be given for a patient with a cardiac disease, especially ischemic heart disease, because ketamine is a drug which increases the systemic blood pressure to a significant extent, and that is why the afterload increases. When systemic blood pressure increases, afterload increases. No, the heart has to pump very much more effort, needing more oxygen, more blood, and can precipitate a myocardial infarction. So, never use ketamine in a cardiac disease patient. You can use ketamine when the patient is in hypotension. That is true. Hypotension, not when the patient is having a cardiac disease. You have to just change that question a bit. That's right. It is also contraindicated in hypertension because it produces hypertension. So, when the patient BP is high, don't use ketamine. When the patient has got a cardiac disease, don't use ketamine. If the patient is having a mental abnormality or got a psychiatric disorder, don't use ketamine. Clear? If the patient has got hypotension, ketamine is the choice. If the patient has got an asthma, ketamine is the choice. I hope all these questions you will remember. That's okay, don't worry. Propofol. Yeah, if the patient is hypertensive, propofol is a good option. That's right, Pushpa. Now, which of these agents is preferred for daycare anesthesia? Very simple question. I am sure that all of you know that. Whenever you see daycare anesthesia, the word daycare anesthesia, there are only 2-3 drugs which you should remember. Number one is propofol for induction, because propofol has no hangover effect. So that is why it is used for daycare anesthesia. Number two, among muscle relaxant, you can use mivacurium or atracurium. Yeah, everybody has got that right. That's right. Mivacurium and atracurium. Third, among benzodiazepines, it is midazolam. So it's very common question. Whenever you see daycare anesthesia, these are the drugs to use. And whenever you see a daycare anesthesia, don't use these drugs like morphine. Morphine has got long duration of action. Thiopentone. Because if you use thiopentone, it has got hangover effect. So don't use it. Okay. Yeah, we don't use ketamine also for daycare because it can have some emergence delirium or dissociative anesthesia and kind of things. Emergence delirium. So ketamine is also not a choice. That's right. Next question. What type of anesthesia is required for dental surgery? For dental surgery, you apply all this: field block, nerve block, infiltration, everything. As you can see from this figure, you can apply topically, you can block the nerve, you can give it in all possible ways you can provide. This is an old question, but since they have asked that, I thought I'll share it with you. Okay. Now, yeah, drug of choice in malignant hyperthermia is propofol. That is right. That is right. Correct. That all of you have got that question. Very good. Okay. Croup and Pushpa, looking into your question, croup and asthma is different. If the patient is if the patient has asthma, you need bronchodilation. Then the choice is a drug which has got a bronchodilator effect, that is ketamine. Okay. Yeah, that's right. Yeah, halothane you can use whenever halothane is a very good bronchodilator. So whenever you have a option of halothane, you can use that, because the essential difference you should understand is halothane is a volatile agent causing bronchodilation, and ketamine is an IV induction agent causing bronchodilation. Ketamine is an IV agent causing bronchodilation, while halothane is a volatile agent causing bronchodilation. So usually they don't mix together. Both can be used in asthma. So in that question about IV agents, I wanted you to answer as ketamine. Suppose it is a volatile agent group of question, then among the volatile agent, halothane is a choice to bronchodilate. I hope the answer is, I hope the point is clear. Now, the next one. Patient had a gunshot injury with hypotension. Rapid infusion of saline is required. Which cannula would you most prefer? Very common question. Yeah, that's right. Most of you got it. Orange. That's perfect. Very good. I'll give you the answer. See, this is how you can recollect. I brought this for you so that you can use it anywhere. Among the question, it is orange, which has got the highest gauge. You can infuse 240 ml per minute. So whenever you are in shock, need a larger transfusion, you always use these three. They are called wide bore cannula. Wide bore cannula. 20 gauges for general anesthesia. Blue, yellow and violet is usually for pediatrics. Clear? Okay. So remember that. So whenever you want a transfusion or a patient in trauma or want to resuscitate, always go with a wide bore cannula. The first three. That's nice code. Now, next question. IV anesthetic agent that cause hypnosis. IV anesthetic agent. First you have to identify IV anesthetic agent. Which are the IV anesthetic agent? Even if you don't look anything else, if you don't look anything else, you can calculate. What is the question? Calculate the rate drop in Ripset. Yeah, 8 macro drop is considered as 16 macro drops is considered. Video will stay on YouTube. Yeah. That is true. That is true. Okay. So IV anesthetic agent, ketamine, propofol, thio, etomidate. These are the IV agents. While rocuronium, vecuronium, atracurium, mivacurium is muscle relaxant. So no question on that. This is volatile agent. CO, DES, halothane is volatile agents. While these three are opioids, and Sugma-Dex is a gamma dextrin, which is actually an antidote of rocuronium. So remember this. So the question is very simple. IV anesthetic agent that cause hypnosis are all this. C. Answer is C. Now, yeah, we have finished the major questions. I'll come to that. We have finished the major questions. Now it is about airway cart. Now airway carts, we have, I am trying to give you a few photographs which has been asked before. So don't get confused. If you get a photo like this, where you can see a laryngoscope. Laryngoscope is simple, as you can see, something like this with a blade. This is a laryngoscope. If you have an additional feature, then it becomes McCoy laryngoscope. Different type of laryngoscopes are there. And if you put some light onto this, it becomes a video laryngoscope. So whenever you see multiple laryngoscopes in a trolley, it is usually an airway cart. So if you can see here, you can see multiple type of laryngoscope. Here there is a CMAC, airway cart, fiber optic bronchoscope, etc. So whenever you see any of this, remember it is an airway cart. Don't make a mistake and tell that this is a crash cart. Okay. Now this is, which is, can anybody tell me what is this one? Extra things we will discuss once we finish this. I will finish it in another 10 minutes. Then we will discuss your questions. Please give me an answer for this. Yeah, Miller blade is used for pediatrics. That is true. This is called video laryngoscope. Video laryngoscope, where you can transmit the figure from here and see it on a screen. Most of you would have used, it's called video laryngoscope. It's not camera, it is video laryngoscope. You can, most of you would have used in COVID times, because when you have got a COVID patient, you can stay away without bending down. You can see it on the monitor and intubate. It's called multiple video laryngoscopes have come, C-track, air track, etc. But in general, you call it as video laryngoscope. So when you have something like this, remember that. This is called combi tube. Combi tube. How do you identify combi tube? There will be two cuff. Don't write it as double lumen tube. Double lumen tube is different. This is combi tube. Combi tube, how to identify is that you have multiple openings between two cuff. That is combi tube. Okay, multiple openings. While double lumen tube has got, double lumen tube will be something like this. Only two lumens. One lumen, lumen 1 and lumen 2. This is the bulb. This is the cuff. Two cuffs here, cuff 2 and two lumens. But here you have multiple openings. This is called, and you can see it has gone into the esophagus. This is the trachea, this is the esophagus. Something which has gone into the esophagus and you can use to ventilate is called combi tube. Combi tube. That means it is compactable to ventilate even if you put it into esophagus. That is how you can remember. A few more spotters. This is called a flexo-metallic tube or non-kinkable tube. This is called an I-gel. I-gel. And this is the very famous supraglottic airway device called LMA, laryngeal mask airway. Okay. Yeah, laryngeal mask airway. The problem with laryngeal mask airway is that it can cause aspiration. It can cause aspiration. That means the contents of the stomach can go into the trachea. Yeah, proceal LMA. I'll show you proceal LMA. This is proceal LMA. Yeah, what difference does it make to traditional ET tube? Yeah, the difference between LMA and traditional ET tube is this. See, traditional ET tube, if you can look here, remember this is our trachea. It branches into two. This is your trachea. The traditional ET tube actually goes into the trachea, inflate the cuff and ventilate through this way. That is why it is called endotracheal tube. Endo means inside the trachea. So endotracheal tube. While an LMA or a laryngeal mask airway stays in the larynx. It actually doesn't go into the trachea. For example, if this is the patient and this is his larynx, the LMA actually stays here and ventilate here. Air delivery happens here. So that is why the air will go into the trachea as well as some amount will go into the esophagus also. So once the esophagus is filled, it will spill over into the trachea causing aspiration. So that's the difference between both. I hope it is understood. Now this is called Pro-Seal LMA, as you mentioned, Pro-Seal LMA. Now Pro-Seal LMA is nothing but a modification of an LMA where through which you can actually intubate a patient. You can put an endotracheal tube through this, which will come out through that, and it will go into the trachea. This is an example of Pro-Seal LMA. Now, can anybody tell me what is this? This is a CVP set. CVP set. This is a single lumen. As you can see, only one lumen here, lumen number 1. And this is 1 and 2 lumen set. And this is triple lumen catheter. Clear? Murphy size is different. Yeah, I'll come to your doubts once we have finished this. Then I'll ask your questions. Yeah, it is used for central line. Now, the point here what you need to remember is this is a guide wire which you use, guide wire. And the guide wire has got a curved tip. See, it has got a curved tip. It is called a J-tipped guide wire. J-tipped guide wire. So it will not injure the vessel when you pass a guide wire. And the process is known as Seldinger technique. Seldinger technique is a method by which you pass a cannula over a guide wire. First you put a guide wire which is J-tip into the vessel, a bigger vessel, so that it will not injure the vessel. And then once the guide wire is in place, you pass the cannula over the guide wire. This is known as Seldinger technique. So Seldinger technique is used to put in CVP. Also our cannula comes under the Seldinger technique. Okay, and it has got multiple lumens. It can be CVP set. You can call it a CVP set also. It has got multiple single lumen set is there, double lumen set is, triple lumen set is there. Swan-Ganz is different. Swan-Ganz is a type of catheter, CVP. It's a type of catheter which is known as continuous cardiac output catheter, where you can actually monitor the cardiac output also, and also by using a thermodilution technique. That is called as a continuous cardiac output catheter. Then it is called, you call it a Swan-Ganz catheter. That's a different thing. Next, coming to the circuits. Breathing circuits is a big concept. The commonest circuit what we use in an adult is called a Bain circuit. I hope all of you will remember. It is called a universal circuit which is used in adults. Okay. Now, what is this circuit? This is called Jackson-Rees circuit. Or it is called Mapleson F. Jackson-Rees circuit or Mapleson circuit. How do you identify? Very simple. Very simple. You just need to look whether there is any valves here. Any circuit without valve is mostly your Jackson-Rees circuit, which is used in pediatrics, because pediatric population cannot hold resistance, and any valves will increase resistance, as you all know. So pediatric circuit is called Jackson-Rees circuit, or otherwise called as Mapleson F circuit. And to identify that, simply look whether there is any valve. Usually there will be a valve attached, but Jackson-Rees circuits usually doesn't have any valves. So remember that. That is how you remember. This is actually the Bain circuit which I was telling you, which is used in adults. The best circuit for controlled ventilation. That means when the patient is paralyzed in adults. You can see inside tube contain oxygen and outside tube contains carbon dioxide. Both tubes on a single axis. So this is known, and inspiratory and expiratory tubes arranged across a single axis become a coaxial circuit. So this is a Bain circuit is an example of coaxial circuit. That is also another question which you can get. This is what I was trying to tell you about APL valve, adjustable pressure release valve, which actually increase the resistance in any circuit. This will be absent in case of pediatrics because you don't want to increase the resistance in a pediatric circuit. So if you look into the previous figure, can you see there is no valve in any of the circuit. None of the area have a valve. So that is why how you can easily identify that circuit. Now when you see, Mapleson F is a modification of ASTPs. ASTPs is modified by keeping a reservoir bag to become a Mapleson F circuit. That is what it is called, Jackson race. Okay, the next one is about this. It is called a trolley which contain a defibrillator, which contain a cylinder, and it also contain multiple trays where drugs are placed. So what is this known as? This is actually the crash cart. When you get a code blue, you give the crash cart. How do you identify the crash cart? By the presence of a defibrillator and IV fluid, cylinders with oxygen, multiple drugs containing trolleys, etc. Okay. So these are the spotters which got through. I think we have gone a bit more than what is expected. And if any questions, you can get back to us. Just message us. We'll give you the answers. Okay, or I'll describe that. And quickly, I think we will have another 5-10 minutes. We will clarify your doubts. Please send me your doubts. I'll just clarify them. Thank you for your patient hearing. Thank you for your patient hearing, and I'll be happy to clear your doubts. Yeah. So the question about soda lime. Soda lime is nothing but soda lime is a component of a canister which is a part of a closed circuit. Closed circuit absorb carbon dioxide and release oxygen, maintaining the humidity. Depending upon the size, you have 4 to 8 mesh of soda lime crystals which absorb that to a tune of 23 liters of carbon dioxide is absorbed by 100 grams, and it is essentially an exothermic process, and the exhaustion of soda lime can be assessed using indicators like phenolphthalein, mimosa red, etc., where you can explain the change of the color. We have a table for that. You can refer to any textbook. You can see the table, but that has not been asked much on to your FMGE exam. Combi tube and ET tube. Of course, ET tube is the best option because ET tube is the definitive one. You can put it into the endotracheal space and then inflate. But the problem with ET tube, you need to do a laryngoscopy and you have to have a bit of expertise to position an ET tube. While combi tube, you have to just open the mouth and thread it into the patient's mouth. It will the tip will go either into the esophagus or into the trachea. In both the ways, you can ventilate through combi tube. That is why it is called combi tube. It is compactable for ventilation in both into trachea as well as into esophagus. I am very happy that you people are very active and giving your opinion. It's very nice to be to interact with such people. Yeah. Color coding is very simple. Don't get confused with that. I think do we have, yeah, color coding. Why should you get confused on that, Dr. Najib? Because see, pin index is very simple. You learn only one pin index, one or two pin index, like Nt and Ox. Common question. You have pin index of 7. Nitrous oxide, it is 3,5. Oxygen, 2,5. These are the most commonly asked pin index for you. Color coding, I already we have discussed it, so there is no confusion for that. Okay. Any further question while getting your guides? You can mail me. I'll get back to you. This is my mail ID. Okay, you can mail me. Send me the questions. I'll solve it and give it back to you. And also you can refer to the app. We have discussed everything in detail in the app, and Doc will help you to solve many of your questions on this. Okay, it has been described in wide or over there. Okay, and please once you finish your exam, please message me or mail me the questions which has come from anesthesia. It will be very nice, so that we can help in continuing the educative process. Okay, this is essentially a recollection which makes us the syllabus more clear, and hopefully that all of you get through this time itself and be wonderful doctors. Thank you once again and very much. Thank you very much for being with me for quite some time in the late night. Thank you. Yeah, you asked about capnograph. Okay, I'm sorry. Dr. Najib wants something about capnograph. Yeah, you can do that. I'll just put, because he has been continuously with me. Capnograph is very simple. This is the capnograph. It's the best method to identify the presence of carbon dioxide in the system. Best method to identify the position of endotracheal tube. This is a normal capnograph. When the patient expires out, no carbon dioxide comes in. That's the basis. Once the alveolar air comes in, the carbon dioxide level goes up. Then it keeps on maintaining there, and finally it falls back into the zero when inspiration start. Okay. So this is the alpha angle. This is the beta angle. Don't worry about that. These are all to be more than 90. Simplest way. The best method, I'll show you few capnograph. If you get a capnograph like this, that means the tube has gone into the esophagus. If you get a capnograph like this, that means it's a curare notch that the patient is breathing. Now, third, what else you need? If you get a capnograph like this is known as COPD capnograph, or the fin appearance. This indicates COPD. When you get a capnograph like this, very big, this is hypoventilation. So every time carbon dioxide will be very high, but the rate will be less. On the reverse, this will be hyperventilation. Capnograph, very small capnograph with multiple numbers. This is hyperventilation. Again, another capnograph which you can come across is suddenly capnograph disappeared. Suddenly capnograph disappeared. That means the tube has been displaced tube, or tubal block. Suddenly the capnograph, another one, capnograph was going normally, suddenly it became big. That indicates hyperventilation, hypermetabolism, like malignant hyperthermia, etc. These are the common questions, but I have not seen much question of capnograph in FMG. That's why. Okay, I think if any further queries, you can mail me. I'll get back to you. Okay, don't worry. I'll be very happy to help you. Thank you. Thanks a lot.